going through techniques, because I'd really like to sort of get a lot of these under our belts by the end of the afternoon. Okay, so let's go and do the easy ones first, and then we'll do some of these more complicated double locking techniques before the end of the afternoon, and perhaps review those again in the morning. Okay, so let's go back to the tables. I'll use Chris if I could, so that here's a big guy. No, laying on your side, please.
Shoes up?
Yeah, can do. Okay, we've got the situation very often, haven't we, where people have got a major loss of lordosis. Just the same as we've got people that are held in this lordotic position with very, very tight paravertebral muscles. We also have the people that are much more locked or emphasizing this particular position. Now, it's difficult to see that people that are like this are going to be held like that with muscle. I mean, the abdominals are not the kind of muscle that would do that particularly. So I think on the whole, this is much more a joint-based thing, an inability of the joint to go into extension, than it is with abnormal muscle contractions holding it in this position. But it is important that we get people to have some degree of lordosis. And if we have tried the passive extension in lying, the Mackenzie protocol, and still as they come up they're pushing from here, and that stiffness is not being achieved by the extension in lying, then all we're going to achieve if we keep on doing this is hypermobility somewhere in extension, and all the rest of it stays stuck. I think that's one disadvantage of just doing it as an exercise protocol, although if people, that's all they need, it's all that we should do. So, Chris, if you could just lay down on your side. Yes, please. All right. So what we're going to do with Chris here is to do a number of procedures which will enable us to get to a greater degree of lordosis. Now, the first technique that I'm going to use is a technique which looks a little bit like the anteroposterior glide that we did, this sort of thing, when we were looking for movement. But of course, now we're going to do it as a mobilization procedure, and I've chosen Chris because he's just about as big as I could manage with this in terms of my size and his size. And so on this kind of a table, it becomes a little difficult. When we've got my moving table, it's kind of a lot easier to do it, and that's, you know, makes a bit of a difference. But I'm going to have to block above the level where I think that the joint is tight. Now, maybe we're going to have to do joint by joint, but let's just take one joint, and let's say that the the 4-5 or whatever is stiff into extension. And so I'm going to block on 4 like that, and 5 I'm going to push back through the sacrum and through the ilia with my leg in a movement like this. So I'm blocking here and I'm pushing with my leg through the sacrum to get a motion like that. I'm trying to get a little bit of a rotation back like that. So it's a little bit like we did with the extension testing. Now, this will be the first of the procedures. The next procedure you could probably work a little bit if you had a partner with you to simulate a situation where, I don't know whether you've seen any of the tables that have the central pillar that you've just put in that goes between the legs if you're going to do distraction on the hip. Okay, these are really useful because let's say we got a pillar in the middle of the table here. I could push Chris forward, I could engage the pillar like that, and now I can get below the pillar and I can direct him much better with both hands back into that way like this, with the pillar holding to stabilize the upper segment. So this is a difficult movement, but it's an important movement because lordosis is a very important movement or posture that we should have. And so these are the two early ones which I tend to use my table, I must say, with this, that I would just sort of release this and just swing this bottom section back and forwards, and I can just hold there, and with the knee piece here I could just kind of move like this, and it moves nice and easily, and it makes it a lot easier, I must say. But without that, and you know, not all my tables do it, so I now come into one of the, most of them have got this central pillar, so I would sort of tend to just work that with the central pillar. However, I could put my arms around there to direct this in the best way possible. But there's no question that just coming in here and holding this and just pushing back with a little turn like that is still a very good technique. But as you can see, it's bringing out a little sweat in me as I go back. Okay? So that's where we will start. Now, because those are relatively easy, what I want to do now is to go on to the next technique, and I'm not really sure how to do this on the setup that we've got here. Okay? It's easy enough when we've got a table that lifts up, so we're going to have to simulate that a little bit. So, Chris, if you could go onto your back here for a minute. And the next thing I need is the wedge. Where is the wedge? Have we got it? Thank you. Thanks, go. All right. Now, what I'm going to do is to take L4 and I'm going to put this across the transverse processes of L4. Now it's obvious that we don't want him dropping down over the end of this, else it's going to be very painful to him. Okay? You'll be able to do this without a wedge, probably with one of the books that you have here, the manuals. You know, that gives you a little bit of a wedge. All right? So this is for extension, all right? So we have the patient in a supine position. If I'd got a table where this end came up, I would be pulling the end up so that he could put his feet up on it, like this. So I've got the table up here, and he's above, is flat on the flat part of the table, and this is up just so he supports himself here. So if we could simulate this a little bit by perhaps just putting a chair like that and see how that works. Now, what I want to do with Chris here is to ask him, and he can do this with the table up quite well, but we'll just see what he does here. Can you just lift up, Chris? And now I don't want you to let yourself down over this wedge, okay? Just want you to keep yourself there for a second.
So the table elevated, where is the crease?
The crease is here. It's only elevated to put his legs up to support it. Now, what we've got now is Chris on this, and I've got to hold him up a little bit. So he holds it until I can get my fingers around, set this thing here, get my fingers around into this position. Now, this is a very specific movement. I'm going to stabilize him over the wedge with my arms like this. And now what I want Chris to do, is that okay, Chris, at the moment, or is it a bit uncomfortable? It's perfectly okay. Fine. Now, what I want you to do is to just think where the edge of that wedge is, and I'd like you to just let your sacrum drop down onto my hand here. And now lift up again, now pull down again, there, and up again, and down again, there. So this is an absolutely specific way of achieving extension at one level. It's a most useful technique, this. Okay, I would do it probably like that for the first day. I kind of prefer with the table to put my hands through the patient's legs, but I think nowadays we're going to be a bit more careful about how we kind of do this. You know, and down again, and up again, and down again. But once they've sort of seen, say, now I think I'd like to try and hold you centrally a little bit. Is that okay? Then I think this is okay, you know, perfectly acceptable. And this is a better technique myself. But with Chris coming up here, I can still hold from here and just lay yourself down over my hand, and I'll control him. Now, the higher we get, the more difficult it is, because you've got a lot more spine to hold so it doesn't jab into the edge of that wedge. So let's see how we do. Chris, if you could just lift yourself up onto your shoulders here, and I'll go much higher up here. Okay, so now I'm into this. I'd probably lift the table so it's now a bit more inclined here so that his legs will be a little bit more on the... So, sorry, Chris, this is probably painful for you. Just with them up there, okay? Because I'm not holding him here. All right, now, I can hold him, and Chris is Okay, now can you just let yourself go down just there, just over the, yeah, that's good. And now push up again and down again. So this is partially a muscle technique, as you see from him, because he's using his abdominals to pull up and then I'm letting it go down and down. And so this is a self-mobilization with me directing him and taking some strain off that joint. I find this to be an absolutely excellent technique for getting very local lordosis and of course extension at one level as opposed to the next level, and well worthwhile with patients with stiff spines to do. Okay, now lift up again and I'll just take this out. Thanks, Chris. So here are 3 techniques that are useful for regaining extension. The side-lying one, gliding backwards. Then I would kind of work with somebody else just putting their arm down here so that you could sort of see what would happen if you had some kind of a block here and how much more easy it is for you to sort of be able to do it like this. Even so, I sometimes do it like this myself, but having my hands here is still a good technique, and I usually start with this and then I introduce this when I know there's some movement. Now, a really stiff back like that, I wouldn't torture anybody by putting them on this. I need to know that there's a little bit of movement there and that I've shown them what to do. And of course, at this stage with Chris, we could be just saying, now, can you pull your back into my fingers here using a contract relax of the back extensors to get here. This is the intent, push back. Now he knows this because he's a smart fellow. Some patients don't know this, they haven't got a clue what to do. And as, not saying, where's Virginia? Yes, when we're working with her, it's really an interesting thing that if you sort of say, now pull back here, the chances are you'll do what Chris did there, which is to round the back. It's really an interesting thing of pull back now, and you can give a bit of resistance here, which tends to focus on pulling the sacrum backwards, which increases the lordosis. But if you say pull back here, Chris will do what he's doing here, which is to flex the spine. So this is a really interesting thing about just the simple difference between doing this, pull back on me here, and so we may have to teach them to do this. But then to sort of say, now pull back, good, and pull back, yeah, that's great, and pull back, pull back, pull back, pull back, like this. And so we can sort of intersperse the control of this as well as when we start getting them to sit and try and learn what to do with this lordosis as they've got more movement. So I think this is one of the really important things to be able to do. Right, let's just try those 3 techniques then. Thanks, Rick. It's only tea. It's good old tea. Okay, can we just think for a few minutes now about one of the most useful of the techniques, which is the distraction. Remember, when we're talking about manual therapy, we're talking about the ability to try to cause glides or the ability to cause a translation movement. So it's a translation movement or it's a distraction movement. We get all uptight in some sort of schools about, you know, the best way to cause a traction on a facet is to rotate. For me, I think of always distraction through the segment. So let me just clarify that. And in the lumbar spine, if we're distracting through the segment, what it will be doing is separating the bodies, as we all know, and gliding the facets like this. So I'm thinking of distraction, not so much as distraction of the facet or total separation of the facet. I use that term. What technique do we use for separation of the facet? We use a rotation rather than calling that a distraction of the facet. So we don't just get confusion on our bad days. All right. Now, there's a variety of ways that we can do this, and you see this in so many different aspects. let me just show one or two techniques here, and there are two things that we should bear in mind. Is one, that if the patient has a deviation, we should always accommodate the deviation, never try and correct it with the traction. The other thing is that if we want some counter traction or counter support, it's probably better to put a belt round the patient with a cushion or a pillow against them and the belt over the pillow. If you are using a technique where they are holding on, get them not to hold on above, because latissimus dorsi can then stop the ilia moving, but to just push on the side so that they are giving a little bit of a counter traction from a pushing movement like this. I know in the auto traction business of Natchev and Lind that they have the arms up and you pull like mad. But in fact, I always sort of wonder what happens to the effect of the latissimus dorsi on being able to stop the ilia moving downwards. And as we need to get the maximum kind of efficiency of this technique, because there are a lot of problems with us pulling down, then I think we need to cut out factors that can absorb some of this force and take it away from the spine itself. So let's just do a number of things here, and you could make up the techniques yourself for here. We can use a belt technique or we can use a hand technique. And one of the ones I'll show to start with is something from one of the earlier courses, is just to simply come onto the legs like this. The whole lot is fastened down. I'll ask Brian just to hold gently onto the side of the bed, although this is an early technique and probably we don't need much counter traction. And I can move back and I can just hold back. I can have a belt round his legs and my hands between the belt and his legs and going round my back, so I just pull back like this using the belt, so I could keep it going for a little longer. And I use this technique reasonably often as far as very acute patients are concerned. Now, if there's a deviation and his shoulders are off to the right-hand side like this, then I would make sure that I didn't pull this way to straighten him out. I would pull along the line of the deviation. So I'm leaving this and I'm actually exaggerating the deviation rather than straightening it, because this is his antalgic position, the position away from pain. So I make sure that I don't kind of straighten it up. If I were going to do this with a one-leg technique, which is sometimes quite easy to do, can you just move down the bed just a little bit, Brian, please? I'll leave his one leg bent, I come into this position, and this is an ideal technique for doing a single leg traction, which is useful when we've got a deviation. So we're not concerned about which side is the painful side. We are concerned about which deviation is present. And we pull so that deviation stays there or is slightly exaggerated. The only consideration of the side of pain that we would make is that these are patients where I would bother to do these techniques where the straight leg raising would be quite restricted, because we're thinking of discogenic problems. So I would obviously not be lifting this leg if this happened to be the correct leg, but he also had pain down this leg, and this was the restricted straight leg raising. I would be making sure that in fact I didn't take it to the point where he was in spasm because of restricted straight leg raising. Now, in the event of having a hypermobile knee, and all that happens when you do this is that the knee comes out, just go from behind the knee, take your hand over here and just pull down in that fashion here, and we can just hold down. And remember, with the more acute problems, the movement is restricted. We pull, we hold, we keep it there, we very gently ease, and then you would probably do another one. We're not bouncing like this. The more reactive, the less the movement that you try to achieve. So, we can do this as a technique where we're using both legs, or a technique where we're using one leg. Now let's take Brian and let's imagine that I want to test the effect of distraction, and perhaps I can do this in the standing position. So if you could like to stand up. And you'll see in the notes that I've handed out, Olaf standing on a small stool lifting a patient, but I mean he's used to lifting 500 pounds. I know that he's on his sequence training, which there's a whole room of it in Mainz, which I teach sometimes in Germany. There's this whole room, and one day in a moment of mad enthusiasm, I decided I would go with Olaf to the training room. So I'm all there in my shorts and everything, and I'm sort of working at one end and watching Olaf, and he gets onto this machine, which was a leg press, and he pushes down on this press, and I see these weights going up and down like this. And I don't know, he's got his belt on, and he just keeps on going, and then he moves on to the next machine. So I get to this leg press, and I push down, and nothing happens. And I set myself, I think, oh, Olaf must have locked this machine somehow. So I get off it to have a look at where the secret lock is, and he's lifting something like, I don't know what, 500 or 600 or 700 pounds or something, like 400 kilos or some incredible sort of weight. So he's standing on a little stool, and he's kind of strong enough to lift many patients, and that's really quite difficult for most of us, all right? But if we just put the patient's arms over like this, and I come in here, or I can wrap my hands around here, instead of doing an absolute lift in the air, I can actually, by controlling the position of the sacrum, I can ask Brian to just lean back on me with your sacrum more, with your sacrum, there. And I can just come into that position and just lean back a little bit, like this, so that I'm just controlling what happens below, and lifting and getting traction is only a semi-specific technique mostly, and several joints are going to be involved in this, of just coming up into this way here, just controlling by leaning back. And on the whole, that is not too strenuous. But I wouldn't suggest, for example, that Deb did that on me. I think it would just be too hard on you. Okay? And we can also think to ourselves, if Brian was deviated, and he was deviated, let us say, this way, his shoulders are over, then I could actually come into this position and accommodate that deviation, and then just try and come back a little bit into the position where I'm accommodating the deviation. And I can look at, perhaps, is there any movement that I can do with a slight rotational positioning that makes this pain better? If there is, then this is a thing to do. And of course, it's fairly easy to just accommodate a variety of combinations sometimes in this position, whereas in lying it's sometimes a little more difficult to do this. So let's start our traction, and there are a lot of different techniques of traction. I'm not going to show you more than about 4 or 5, okay? And they're all basically the same principle. Carl Levitt in his book says that mechanical traction is a thing that's used very widely all over the world, but none of it is anything like as good as the manual traction given by a skilled therapist. So he really espouses the thing of doing it manually. I sometimes used to think with some of the European clinics, and I won't mention any names being as I'm on on here, that it was just because they used to encourage all these belts and straps and things because they were too cheap to buy a true track. But I'm not so sure that that is actually a very valid thing. But on the other hand, I think that if we found a combination of movements and then the mechanical thing will do it equally well, that it would be a waste of our effort and time to continue to do it. But just early on, this is a very, very useful sort of thing for the acute patient, because there's nothing worse, is there, than having somebody on a table that you can't get them off the table. It's an interesting thing that when I look at the way that I practice and all of the things that I've ever done to patients, that the only 2 patients that have ever had to be taken from my clinic by ambulance were 2 that were on lumbar traction. One that I couldn't get off the table, but I wasn't too keen about putting them on, but I knew that some kind of traction was necessary because I was sure it was a big disc. There were no hospital beds, so the doctor said, look, just put them on, and if you have trouble getting them off, because I'd warned him about all this, he said, this will be no problem because we can get them in on an emergency basis, and that's what happened. The other guy, when you think about everything that can go wrong, I got him on the table. It was late on one Saturday morning. He got off the table. I spent a lot of time getting him up and off, and he felt quite good. I put his shoes on for him. What I didn't know was that he had overshoes on out in the reception area. So he bends down to put his overshoes on, in spite of the fact I told him no bending. I want you to walk around for at least half an hour after this before you get in your car. What happens, of course, you look at him. He comes from 45 miles away. He isn't married. He's got a car there. So I had to take him home by car, you know, and then he had to organise for somebody to pick his car. 3 days later, I just put him to bed and told him to put some ice on, and some of his neighbours came in, like farming communities do, and looked after him, and 3 days later he was okay. But this was the only two that I can remember. One that had to be taken out by ambulance, one that I kind of was the ambulance and staggered him out of the clinic. Okay, so this was from traction. It wasn't from manipulating or all the things that we usually do. It was the thing that most therapists do for backs, which is traction. And one of the things I think we should remember about traction, the point that Cyriax made very early on, that if you've got severe pain and there is a major reduction in the pain, don't celebrate. Very quickly, but in a very controlled way, I mean in a short period of time, try and get the traction reduced to some point where the pain comes back, because always the rebound effect is phenomenal if you totally remove the pain. Everybody's happy, the patient's there, until you try to wind them down. And then you've got big problems. Now, I've no experience with incremental tractions or any of that. You know, my true track is kind of old and it just pulls and relaxes in, but it doesn't do it in this incremental fashion. If anybody's got any great experience, or Jim, your experience with the auto traction, this would be something also to talk about to the group when we've done some of this, when we need a bit of a rest. So we will come back to that. And I'd like you all, in terms of, you know, your own experience with any of these things or anything that's similar to this, then let's sort of share experiences between all of us. So if we're feeling flush and you've got a $30,000 piece of equipment, we feel we really should go rush out and buy one, we'll do it on Monday. On the other hand, if you've got like a $500 piece of equipment that does everything, that'd be great. Okay, so there we've got the standing technique, and we've got the two techniques, and we're not going to spend much time on these three things because you've done them all before, but just to sort of refresh your mind as to what some of these traction things are. And the last thing I'll just show you in this group is, can you lay down on your stomach? One of the ones that Lewitt talks around, and I haven't used this one for a long time. I'd kind of forgotten until I was looking at this course and just thinking to myself, okay, what are the sort of varieties of this? And I always read Levitt because I like his book. But I hadn't read this little bit, and it was kind of interesting. He has a technique where he's talking about putting a traction through both legs with the patient in prone, and then getting a little oscillation going, and he's talking about the importance of the oscillation, that by moving very gently, you gradually feel that you've taken up the slack in the knee and the hip, and now what you're getting is an oscillation which is into the back. Now, we'll ask Brian, where do you feel that, Brian? Through everything, or?
It feels great. I feel it in my back.
Okay. Couldn't have picked a better guy. Okay. So, once again, with Brian, we'd probably be better to ask him, could you put your hands at your side and just lightly grip the edge of the table? These might not be the best to do, just if there is a small spot that you could. So, don't push particularly, but just give me a little tiny bit of resistance to see if it makes any difference, what you would have been before. Okay, that's good.
Yeah, I feel more now.
Okay, so this would be a good thing rather than the arms above the head, where latissimus dorsi is going to be absorbing some of it, must do, some of the ilial movement. And so his point is that this is really important, this little oscillation that you can get going. So watch your own back. There. So this is the thing I'm going to try a little bit more of when I go back. It's something I used quite a long time ago, and it's one of the things I'd just forgotten about. You know, you do this, don't you? I seem to be losing more and more. But this sort of gentle oscillation is quite good. So remember what we've done. We've done the prone lying with a distraction. We've done the prone lying with trying to accommodate a deviation. Then we did it through one leg, and the last thing that we did was the oscillation. Just before that we did the standing one. So these are all varieties of sort of traction.